So in this episode of Medication Mondays, we're talking about amitriptyline. Amitriptyline is an interesting medication. It's been around for a long time, and I think I'd like to think of it as a bit of a shotgun medication in that it has an effect on a lot of different receptors and therefore has a lot of different effects and side effects and indications. So I thought it was an important video to make so that we can talk about it and try and simplify what is a very complicated drug. But a drug that has been here for probably about 50 years and will probably be here for hundreds of years to come. So the structure of this video will be that we'll start a bit about how the drug works and what it's used for, the indications. We'll talk a bit about the side effects. We'll talk about the use of this drug in special populations, children, elderly adults, people with different metabolic rates. We'll talk about the dosing of the drug, the kind of range of doses and different indications. And then finally, we'll just talk a bit about general, what we call clinical pearls, important facts and trivia and tips on how to use the medication. If you're new here, by the way, my name's Dr. Sil. I'm a junior doctor training to become a psychiatrist from Australia. And in my free time, I make mental health educational content. If that sounds like your cup of tea, consider subscribing. All right, let's get cracking. So amitriptyline is often talked about as an antidepressant, which is fair enough. It does have that's probably the majority of its use, but it's also used in a lot of other things. So it's indicated in neuropathic pain syndromes. So that's people who have pain that has the root of the pain is the nervous system, not like a cut in the skin or a blunt trauma. The pain is actually coming from the nerves. The third indication is chronic pain. So people with chronic lower back pain can benefit from a trial of amitriptyline. But it's also used in like migraine. It's used in people who have incontinence issues. And other mental health indications include anxiety, so generalized anxiety disorder and other anxiety disorders, and insomnia, because it does help with sleep efficiency, which we can talk a bit more about later, what that means. Yeah, so in terms of how the drug works, it's a bit of a shotgun. It has an effect on a lot of different kind of neurotransmitter receptors. So the two main ones are the serotonin reuptake transporter. So as a bit of biology, when two neurons are talking to each other, they spit out these kind of messengers. We call them neurotransmitters. And that goes into the space between the neurons called the synapse. And when that messenger is spat out, it also has to be sucked back in to reset. And those are the reuptake proteins. They reuptake the transporter. And when it's serotonin or as well the norepinephrine neurotransmitter, then this drug, amitriptyline, actually blocks those reuptake pumps, which means that they have a stronger effect. So serotonin and norepinephrine have stronger effects. We are not 100% sure why that results in an antidepressive effect. The brain is very complicated, but it seems to help produce this thing called BDNF, a brain-derived neurotrophic factor, which makes neurons more malleable to forming newer and hopefully less depressive and more adaptive circuits. But this drug also affects histamine receptors, so it's an antihistamine effect. It has an anticholinergic effect, which we can talk a bit more about what that means as well. It also has a direct binding to some opioid receptors as well, which might be how it helps with pain. Now, the effect can take a while to happen. It's not like an immediate effect. If someone's depressed one day and they take a tablet, they might not even feel anything the next day. So it's usually about 4 weeks to have a good trial. So a good trial at a good dose, usually 4 weeks is considered a good trial. You should start feeling some changes within 4 weeks. If you're taking it for depression, within 2 weeks, you should start feeling some changes. If you're taking it for depression, strongly suggest doing some psychotherapy as well with a psychologist, because we talked about how it can maybe help your brain form more adaptive circuits. That's a really good time to start doing psychotherapy to help form those healthier, happier circuits, I guess. Now, if you haven't felt any changes within 2 to 4 weeks, don't just give up. There might need to be a dose change, but you have to talk to your doctor about that. When we're using amitriptyline in depression, the goal is really, the elimination of depression symptoms. Depression is a treatable illness. It's not curable, but it is treatable. When it's being used for things like chronic pain, it's usually about reducing the intensity of symptoms. I've also heard about it being used in like itch and cough without a known cause. And there again, it's about reducing the symptoms. And some studies have shown that it reduces coughing from unknown causes. So some people, by the way, will just have a chronic cough and no identifiable, lesion or cause or infection causing that cough. In those people who try it, I can reduce the cough by 50%, which is pretty considerable, seeing as it's a very hard thing to treat when we can't find the cause of the cough. If it's being used in depression, it's not considered a first-line medication. It used to be, by the way. This back in the day when it was used, it was probably one of the first medications, it was one of the first medications used in depression. But because of the side effects that come with it, and obviously it'll have lots of side effects, it has lots of side effects because it hits so many different receptors, like we talked about. But because of those side effects, it's considered a third-line agent, actually, where I work. So it kind of depends what you've tried before, what side effects you can tolerate. Everyone's receptors on their neurons are different. So everyone has a unique experience. So it's impossible to predict whether it's going to work for you 100%, but it's worth trying. And that's often kind of how it ends up in depression is we don't have very good tools to predict what medication will help. So we just kind of trial the least disabling medications, I guess, the medications with the least side effects. And even those have side effects, by the way. But usually people will start with an SSRI, then another SSRI, then maybe an SNRI, and then maybe a tricyclic antidepressant. Don't worry if you don't know about all those acronyms I just used. I'll make plenty of videos about them at another time. It's a good point to note that some people with depression might have a bipolar illness, but not yet have had a manic episode. You have to be you essentially can't use this medication in someone who gets mania. It is very serotonergic and does predispose to having manic episodes. The other significant no-no, I guess, with this medication is that it is just extremely toxic in overdose. So people who are, have a history of suicide attempts or considering and having ideation, it's just it's a shame because it's an effective antidepressant, but it's just not worth the risk, and it's not that effective that it justifies the risk in someone who's considered a high suicide risk. Of course, this is a case-by-case decision that your doctor and you will make with a shared decision-making model, talking about the pros and cons, but it's just quite toxic in high doses. So yeah, you have to be cautious about that. It can be augmented with other medications if people have only had a partial response. So in depression, we could use lithium, we could use buspirone, although that's not done much in Australia. And sometimes thyroxine is used in depression as well, just to boost the energy levels. And in pain, it might be used with pregabalin or gabapentin. These are other pain treating nerve pain medications. In terms of tests to do with your doctor before starting this medication, you don't have to have an intense blood panel, but I suggest everyone with first episode depression should get one, because there are biological causes to depression that you can find on blood tests, like problems with thyroid levels or iron, or anyway, let's not get into the causes of depression, but it's worth getting a set of bloods. But definitely you need to do BMI. Okay, this medication is associated with weight gain, so it's important to monitor that. You can do ECGs of the heart. And it's also, yeah, you can monitor electrolytes as well, if especially for people who are on like diuretics or medications that can affect electrolyte balances. People with problematic kidney disease, that you should have regular blood tests. Your doctor will decide on the frequency. Depends how stable things are. Now, in terms of the side effects, there are, let's talk about side effects. It's considerable. There's the anticholinergic side effect group. So it binds to the acetylcholine receptors and blocks them, which causes a set of side effects that they can be very disabling for certain people. These side effects include like dry mouth, dry eyes, constipation, as well with the antihistamine effect together can cause significant sedation. So very sleepy, can make people very sleepy, which, by the way, is why it is given at night. The antihistamine effect can also be associated with weight gain, so it's important to monitor weight, as we've said. And there's also an anti-alpha-1 adrenoreceptor activity. What that means is it can cause postural hypotension. So what that means is it can cause lightheadedness on standing. So someone's elderly or has problems with their vascular tone, the tone of their blood vessels, which can be seen in things like Parkinson's disease and other neurological conditions. If people get lightheaded when they stand up, this can make that worse, and it can be catastrophic. People have lost consciousness, have fallen, have had head strikes, have had brain bleeds. So it's not something to minimize. It is something we need to be aware of. Now, in overdose, it is not good for the heart. It can block ion channels and cause cardiac toxicity. It also can prolong something called the QT interval, which is the time that it takes for your ventricles of the heart to repolarize after they contract. So that's why we do those ECGs. By the way, an ECG is when we put dots on your chest and we monitor the electricity of the heart as it does heartbeats. Now, if someone's getting side effects that are considered mild or even sometimes moderate, the best thing to do is wait. Try the medication. Often those side effects will abate and normalize and stop. It just needs to be monitored closely with the doctor, but there is a level of acceptance of tolerance to side effects that can be really helpful because they do get better. Over 2 weeks, dry mouth and things can get better. If they're continuing, you can try a reduced dose, or you might need to do a medication change if you're having any serious side effects. And usually the medication change will be towards like a SSRI, one of the antidepressants with less side effects, or a newer antidepressant, such as like, I don't know, agomelatine or vortioxetine. Talk to your doctor, right? This is not medical advice. This is just some ideas to talk about. Now, the dose kind of depends what it's treating. In chronic pain and neuropathic pain, 25 to 50 milligrams is pretty common. In depression, it's usually 50 to 150. I haven't seen over 150, but some psychiatrists with very close monitoring might try over 150 milligrams a day. But 150 is the most I've seen. And the doses should be given at night. Some people split it in the day. That might help with side effects. So, for example, they might have 25 in the morning and 75 at night. It's good to have the bigger dose, the 75 dose at night, just because of that sedative effect, making people sleepy. Now, some people might develop this strange anxiety and restlessness and activation and expansive affect, and if that's happening, you need to be very cautious that this isn't a manic episode, because it could be. This can induce a manic episode in people who are vulnerable to developing a bipolar illness. Now, it's considered a safe medication for long-term use and a medication that is not habit-forming if someone needs to stop the medication. Textbooks say 50% reduction for 3 days and then another 50% reduction for 3 days. My personal practice is to slow that down more. I guess it depends if you're replacing it with another medication with similar effects or if you're stopping completely. But stopping antidepressants is probably an area that needs to be improved, because there's discontinuation syndromes that can be very disabling with very significant withdrawal effects for some people. But if it's done slowly, gradually, and not rushed, it's safe and it can be done quite easily. Now, in terms of drug interactions, there are significant drug interactions. So, best bet is to talk to your doctor, or you can use a drug interaction tool online where you type in the medications you're on and amitriptyline, and you look for interactions, and bring that to your doctor to discuss whether that's relevant or not. Because there's 1,000 theoretical interactions with drugs, but not all. Most of them are not that clinically relevant. So I guess if you're taking any other medications that are anticholinergic, like benztropine, or if you're taking any other antidepressants, or if you're taking any other medications that affect the sympathetic nervous system, so maybe some antihypertensives, all these things can interact with the amitriptyline. So just note it, bring it to your doctor, ask for a bit of a discussion, or otherwise you can do the drug interaction checking tool yourself. You just go to Google, type in drug interaction checker. Don't believe everything verbatim. Bring it to your doctor for a kind of review of the interactions to discuss how clinically relevant they are. And that's a good point that just come to my mind. If someone has had a recent heart attack or has significant heart disease, this is not the medication for them. There's just other alternatives that aren't as toxic to the heart in high doses. At normal or low doses, it's safe for the heart, but it just can become risky very quickly. So it's best avoided if possible. Now, if we talk about kind of the special population groups, people with kidney disease, it's okay at low doses. You probably need lower doses though, because of the electrolytes and the clearance of the medication to avoid a toxic buildup. And the same goes with people with liver disease. When it comes to people with cardiac disease, I would just avoid it unless there's an expert with experience using this medication with people with cardiac disease. There's just the risk benefit has to be considered, but the risk is quite significant. People have had kind of sudden cardiac death from from a group of causes, but one of the contributing factors to their death was the fact that they were on an tricyclic antidepressant. This is super rare. I'm not trying to promote fear, and if you don't have cardiac problems, I can't say it's impossible, but it's pretty close. So it's just a kind of warning that if there are cardiac risks, talk to your doctor. In the elderly, it's also used at a lower dose because of the decreased metabolic rate and clearance from the kidneys and the liver. And in kids, it's not used in kids less than 12 years old. And it just needs much more frequent reviews for the side effects. And especially with adolescents, as they grow up, you need to monitor for sexual side effects as well, which is, I guess that's true for all adults. And I don't know if I mentioned that before, but one of the side effects is sexual side effects. So that can be problems with libido, it can cause erectile dysfunction. It can cause problems with ejaculation and orgasm. So those are significant side effects to consider as well. And sorry, coming back to the special populations, it can be a useful medication for people who have like bedtime wetting at any age, usually over the age of 12, but even adults. So if people are wetting the bed in their sleep, this can be a medication that can help. And I think the mechanism of that is around that anticholinergic side effect. In pregnancy, it's always tricky in pregnancy because the studies are not great, and it's usually animal studies because you can't just test on people who are pregnant. But often you have to consider the risks of taking the medication versus the risk of not taking the medication. And if someone has a serious depression, and when they're not being treated, they stop eating, they stop getting out of bed, that is a very significant risk to the fetus because the mental state of the mum is absolutely critical. But there are animal studies that do show, one, that amitriptyline does cross the placenta. It does go into the fetus's circulation, and that there were some adverse effects in the children, such as withdrawals and increased amounts of lethargy, like they were more sleepy. So, it wasn't life-threatening, but it is significant and worth considering. And for breastfeeding as well, it does cross into the milk. So it is found in the milk of people taking amitriptyline. So in that case, it's probably best to bottle feed. or to try a different medication, or to stop the amitriptyline if people are breastfeeding. So again, you just have to make a risk-benefit judgment. And so now for the kind of clinical pearls section, I've got a list of kind of interesting things to talk about. The first is this used to be the most common antidepressant in the world, and now it's still one of the most favored medications for migraines and for neuropathic pain. Second thing is, with a medication like this, it's important to stay well hydrated. People who are dehydrated are at increased risks of the side effects, especially the ones on the heart. So staying well hydrated is key. There is some weak evidence that tricyclic antidepressants are more effective than SSRIs for depression in men, but in women, maybe SSRIs are more effective than tricyclic antidepressants like amitriptyline for depression. So there might be a gender effect. And the final thing to talk about is there is a range of people's metabolic profile for this medication. So in studies, they have found that there's like low metabolizers and then ultra rapid metabolizers. And those people who metabolize it very quickly will need a bigger dose than the people who metabolize it very slowly. And this isn't saying anything, specifically about the person's health. It's just what enzymes they have in their liver genetically. But the point is that some people might need very low doses of it to have the effect. Other people might need very large doses of it to have the effect. So everyone's different. That's why it can sometimes feel like a bit of an experiment and trying to find the right dose. But, as a closing statement, be patient, work with your doctor, report all the side effects, and I just wish you all the best. That's everything I wanted to talk about in this video. I hope you found it helpful. If there's any questions, put comments down below, and I'll see you at the next episode of Medication Mondays. If you want to support the channel, please consider subscribing and liking the video. That'd be great. Yeah, that's it for me. Okay, have a lovely day. Bye for now.